Wow. Preparing for this deep dive today, I got to say, I was really struck by like just how many people around the world have asthma.
Yeah.
It's one of those things you hear about it, but you don't always realize like the sheer scale of it.
It's a really prevalent condition.
Yeah, yeah, absolutely. The numbers are pretty eye-opening. Depending on, which country you're looking at, it could be anywhere from like 1% of the population, which is, still a lot of people,
Right.
all the way up to almost 30%.
29%, yeah, which is huge.
29%, which is, yeah, just a massive proportion of people.
Hmm.
So, clearly this is something it's a major health concern globally.
Absolutely.
And that's why we're diving into this today. We're talking about the 2024 Global Strategy for Asthma Management and Prevention Report. This is from the Global Initiative for Asthma, or GINA.
GINA, yeah.
And this report, I mean, this is not light reading. This is like
It's the Bible of asthma.
yeah. It is, yeah. It's dense, but it's the gold standard, right? This is what healthcare professionals, policymakers, everyone involved in asthma management, this is what they look to.
It is, yeah.
So think of this deep dive then as kind of like your cheat sheet, right? We're gonna distill all of this complex information. We're gonna pull out the key takeaways, the most insightful things, the things that really matter for you, the learner, no matter how much or how little you might already know about asthma.
Right, exactly. We're cutting through that complexity and giving you the essence of what you need to know.
Exactly, yeah. So whether you're a patient, a family member, a healthcare professional,
Mhm.
or just someone who's interested in learning more about this condition, hopefully by the end of this you'll have a really good grasp of the essentials. All right, so mission, should you choose to accept it, and you are, is to really get down to the nitty-gritty of asthma. We're going to talk about, how's it defined nowadays, what's the latest thinking on what asthma actually is, how do we diagnose it, and that's a really key part. What are the most up-to-date treatment approaches? And then also kind of zoom out a little bit and look at some of the big picture challenges in managing asthma
Yeah.
globally, access to care and things like that.
Absolutely, yeah. And I think before we jump into that, I think just even starting with how we actually define asthma today is fascinating because it has evolved.
Right.
So asthma, the current consensus definition is that it's a heterogeneous disease. And what that really means is it's not one size fits all.
Right. Okay. Heterogeneous, meaning it's different. It presents differently in different people.
Exactly. It presents differently. The underlying mechanisms might be slightly different. However, the common thread is chronic airway inflammation. That's kind of the hallmark. And then on top of that, it's characterized by a history of respiratory symptoms that vary over time and in intensity. And these respiratory symptoms can include wheeze, shortness of breath, chest tightness, cough.
Right.
And it's also associated with variable expiratory airflow limitation. So that's the other piece of the puzzle.
Okay, so that variability, that coming and going, that seems to be a really important part of it, not just constant breathing problems.
Yeah, that's really important because, as we'll discuss later, it plays a big role in diagnosis. So, we're not talking about people who have difficulty breathing all the time. We're talking about people whose symptoms and whose airflow limitation varies over time, and they can be triggered by a variety of things. Exercise, allergens, irritants like tobacco smoke, changes in weather, even infections. So this variability is a key feature, and it's particularly important before someone starts on inhaled corticosteroid therapy, which is often used to treat asthma.
Right. ICS, yeah. Okay, so that brings us to diagnosis. And it sounds like, from what you're saying, getting that initial diagnosis, getting that right from the start is really, really important.
Absolutely. It's fundamental. And in fact, the report really emphasizes diagnosing asthma before starting any inhaled corticosteroids because those inhaled corticosteroids can actually reduce that variability.
Oh, okay, so it can actually mask the symptoms.
Exactly. It can mask the symptoms. So you can have someone who has asthma, they start on inhaled corticosteroids, and suddenly their symptoms improve, their lung function improves, and then it becomes much harder to actually confirm the diagnosis later on.
Oh, wow. Okay, so that's really tricky. So then what are the things, what are the key things that healthcare professionals are looking for to make that initial diagnosis?
There are two key things. First is that characteristic pattern of respiratory symptoms that we talked about. So the wheeze, shortness of breath, chest tightness, cough, that kind of fits the picture of asthma. And the second key thing is objective evidence of variable expiratory airflow limitation.
Right. Okay, so that actual measurement of how well their lungs are working and how that changes.
Yeah, exactly. So it's not enough to just have the symptoms. You need to have that objective evidence as well. And it's really important to emphasize that we're looking for variability.
Yeah.
It's not just that someone has poor lung function, it's that it varies over time, and it varies in response to things like treatment with bronchodilators.
Okay, so how do they actually measure that airflow limitation, that variable airflow limitation?
So the most reliable way to do that is with spirometry. And spirometry it's a lung function test where you basically breathe into a machine and it measures how much air you can blow out in 1 second, which is called your FEV1. It also measures your total amount of air you can exhale, which is called forced vital capacity, or FVC.
Got it.
And the relationship between these two, the FEV1 FVC ratio, is a really important clue.
Okay.
Now, it's important to highlight here that spirometry should be performed by trained personnel using well-maintained equipment.
Right.
There are very specific guidelines for how it should be done, but as you mentioned earlier, spirometry isn't always available everywhere, especially in resource-limited settings.
Right. It's not universally accessible.
Absolutely. So in those situations, healthcare providers might use peak expiratory flow, or PEF.
Right. That's the handheld one.
Yeah, that's the little handheld device where you basically blow into it as hard as you can, and it measures your peak flow.
Right.
And you can do serial measurements and see how that varies over time. It's not as reliable as spirometry because it can be affected by things like how well you do the test, but it's a useful alternative when spirometry is not available.
Okay, so what are they actually looking for in those measurements? Like, what are the actual numbers that would suggest that someone has that excessive variability that's consistent with asthma?
Yeah. So for spirometry, one of the key criteria is an improvement in your FEV1 of at least 12% and 200 milliliters from your baseline
Okay.
after you've used a bronchodilator.
Right, the medication that opens up the airways.
Exactly. And
Okay.
conversely, if your FEV1 worsens by 12% and 200 milliliters or more, that can also be suggestive of asthma.
Okay.
With PEF, the criteria are a little bit different. We're looking for a change of at least 20%.
Okay.
So either an increase or a decrease of 20% or more from your baseline. Now, these are just, rough guidelines, and they're still being debated and refined. But they give you an idea of what healthcare professionals are looking for.
Right. Okay, so that's kind of the classic way that asthma presents, but I know there's some less common ways it can show up as well, right? Like I think I read something about cough variant asthma.
Yeah, cough variant asthma is a fascinating presentation where the main symptom, sometimes the only symptom, is a persistent cough.
All right.
And this cough might be worse at night or with exercise. And interestingly, their lung function tests, even spirometry, might be completely normal.
Oh, wow.
However, if you do other tests, like a methacholine challenge test, which is the test to see how reactive your airways are, they might have what we call airway hyperresponsiveness.
Okay.
So their airways are more sensitive than normal, which explains why they're coughing, but it's not showing up on the standard lung function tests.
Interesting. So it's really important to differentiate that from other things that can cause a chronic cough.
Absolutely, yeah. It's a diagnosis of exclusion. You got to make sure it's not something else.
Right. And what about asthma that might be related to someone's job?
Ah, yes, occupational asthma. Another really important area to consider. So this is asthma that's either caused by new exposures at work or, more commonly, exacerbated by exposures at work.
Right. Okay.
So you already have asthma and you're exposed to dusts, fumes, chemicals in your workplace, and your asthma gets worse. And it's thought that a significant proportion, like 5 to 20% of new onset adult asthma, may be attributed to work.
Wow.
So it's really important to think about that in the context of someone's work history. And a really important clue is whether their symptoms improve when they're away from work.
Right. Yeah. Like on weekends and holidays.
Exactly, yeah. If they notice a pattern that their asthma is worse when they're at work and better when they're not, that's a big red flag. And it's really important to confirm the diagnosis objectively because it has, it can have implications for someone's work, for their health, for their legal rights.
Right. Compensation and things like that. Okay, so it sounds like diagnosing asthma isn't always a straightforward thing. Are there other, patient groups or populations where it can be particularly challenging?
Yeah, absolutely. So, for example, in athletes, diagnosing asthma can be quite tricky because they might have other things going on that can mimic asthma. Okay, yeah, I can see that.
Like problems with their nose, vocal cord dysfunction,
Mhm.
even just being deconditioned. So, they might have shortness of breath with exercise, but it's not actually asthma. So they'll often do lung function testing in athletes, and they may even do something called bronchial provocation testing, where they actually try to trigger their symptoms in a controlled setting,
Right? Okay.
and that can help them differentiate asthma from other conditions. And then in pregnant women,
Yeah, that's a whole other.
that's a whole other ballgame, yeah.
Yeah.
So generally, with pregnant women, we try to manage them based on their history and symptoms,
Okay.
and we avoid doing bronchial provocation testing.
Yeah, right, yeah.
If their history strongly suggests asthma, but their initial lung function tests aren't conclusive, they might start treatment with an ICS and then do more detailed testing after delivery.
Got it.
It's also important to note that ICS treatment should not be reduced during pregnancy. Okay, so if they're already on it, keep them on it. Got it. We mentioned earlier the challenges in lower income countries. Are there any other specific populations where getting a diagnosis is particularly tricky?
Yeah, I think people who smoke or have a history of smoking, they can be a diagnostic challenge
Oh, right.
because their symptoms might overlap with COPD, which is chronic obstructive pulmonary disease.
Right.
And it can sometimes be very difficult to differentiate between asthma, COPD, and what we call asthma COPD overlap syndrome, ACOS.
Right. So it can be a mixed picture.
Exactly. And GINA actually refers to another set of guidelines, the GOLD guidelines,
Okay.
for the diagnosis of COPD. And the GOLD guidelines look at, they look at the patient's history of symptoms, their exposure history, and spirometry
Right.
after bronchodilator to make the diagnosis.
Okay, so lots of different considerations there. So let's say we've, hopefully gotten a clear diagnosis. What's the next step in terms of managing someone's asthma?
So the next really important step is to assess both their level of asthma control and their future risk of adverse outcomes. And these two things, asthma control and future risk, are the cornerstones of asthma management.
Okay, so let's break that down then. What does it mean for someone's asthma to be like well controlled or poorly controlled?
Yeah, so asthma control really refers to the extent to which the manifestations of asthma are present in the patient or have been reduced or removed by treatment. And it's assessed in two domains: symptom control and risk factors for future adverse outcomes.
Okay, so the symptom control, that's kind of like how are they doing right now, day to day?
Exactly. So day to day, how are your symptoms? Are you waking up at night? Are you having to use your reliever a lot? That's what I mean by symptom control.
Right.
And then the risk factors for future adverse outcomes, that's more about, okay, what's the risk that this person's going to have an exacerbation?
Right.
What's the risk that their lung function's going to decline?
Okay, so that's more long term.
That's more long term. What's their risk of side effects from medications? So it's really important to assess both of those things.
And how do doctors assess that symptom control in a practical sense?
So they'll typically ask you about, how often you've had symptoms during the day, at night, if you've been woken up by your asthma, if your asthma's limited your usual activities, and how often you've needed to use your SABA, your reliever, in the last 4 weeks.
Okay, so it's really that recent history that they're focusing on.
Yeah, it's that recent history. There are also some standardized questionnaires that can be used,
Right.
like the asthma control test or ACT and the asthma control questionnaire or ACQ, that can kind of help quantify the symptom control.
Okay, got it. And then on the risk side, what kind of factors are they looking at to figure out what someone's future risk might be?
Yeah, so there's a bunch of risk factors. Having one or more exacerbations in the past year is a big one.
Okay.
Frequent SABA use, and by frequent, we usually mean needing 3 or more canisters a year.
Okay, so they're really going through a lot of reliever inhalers,
Exactly, yeah.
right?
That's a sign that their asthma is not well controlled. Inadequate ICS treatment or poor adherence to ICS treatment is another one.
Right, so they're either not on it or they're not taking it like they should be.
Exactly. Incorrect inhaler technique, obesity, rhinosinusitis.
Okay, so that's chronic sinus problems.
Chronic sinus problems. GERD, which is gastroesophageal reflux disease.
Right, the acid reflux.
Yeah. Food allergy, smoking, exposure to air pollution,
Right.
even psychosocial issues like stress. All of these things can contribute to future risk.
Right, so it's really this whole, biopsychosocial model of health, all these different things kind of feeding into it. Okay, we've talked about control, we've talked about risk. The report also talks about asthma severity. How does that fit into all of this?
Yeah, so asthma severity is a little different. Asthma severity is a retrospective assessment of the intensity of treatment required to achieve control.
Okay, so it's kind of looking back in time.
Yeah, looking back in time, usually over the past 2 to 3 months.
Okay.
So basically, how much treatment did this person need to achieve good control?
Got it.
And it's usually categorized as intermittent, mild, moderate, or severe. And it's really useful, particularly for identifying patients with severe asthma who might need additional therapies, like, for example, biologic therapies.
Right.
So I think one way to think about it is control is how are you doing right now?
Okay.
Severity is how much treatment did it take to get you there?
Right, right. So someone could have very severe asthma, but it could be well controlled with the right treatment.
Exactly,
Yeah.
exactly. They might be on very strong medications, but their asthma is well controlled.
Right. Okay. That makes sense. Now, you mentioned mild asthma, and I think a lot of people, when they hear that, they think, oh, mild, that's not a big deal. But it sounds like there's some important nuance there.
There's a big caveat there. So there's ongoing discussion about the definition of mild asthma. And the report makes a really important point, which is don't equate mild asthma with low risk.
Right. Okay.
So even patients who have mild asthma or infrequent symptoms, they can still have severe exacerbations if they're only using a SABA.
Oh, wow. So even though it seems mild, they could still have a really serious asthma attack.
Absolutely, yeah, because that underlying inflammation is still there. So it's really important to assess both symptom control and risk factors in all patients with asthma, even those with mild or infrequent symptoms.
Got it. So don't let that mild label lull you into a false sense of security.
Exactly.
Okay. So we talked about diagnosis, control, risk, severity. Let's move on to how we actually treat asthma. It sounds like the report kind of lays out two main approaches.
It does. So GINA now presents asthma treatment as two main tracks.
Okay.
And the preferred approach is track 1. And track 1 focuses on the use of what they call an anti-inflammatory reliever, or ARR.
Okay. AR. What's that?
Yeah, so AR usually involves a low-dose ICS formoterol combination inhaler. And formoterol is a LABA, it's a long-acting beta agonist, but it also has a very rapid onset of action.
Okay.
So it can be used as a reliever.
Right. So it works in two ways. It's a long-acting preventer, but it can also work quickly as a reliever.
Exactly, exactly. So in steps 1 and 2 of asthma management, this ICS formoterol combination inhaler is used as needed for quick relief.
Okay.
Then in steps 3 to 5, it's used as both maintenance and reliever therapy, or what we call MART.
Right. Mort.
MART, yeah. And the evidence really suggests that this approach is more effective at reducing exacerbations than using a SABA alone.
Okay. So that track 1, that's the preferred approach using this combination inhaler that can do both jobs. And what's track 2?
So track 2 is the alternative approach.
Okay.
And in this track, the reliever is either a SABA as needed or a combination ICS SABA inhaler as needed.
Right. So they're still using a reliever as needed, but it might not be that dual purpose one.
Exactly, yeah. And this might be an option if track 1 is not feasible for some reason, or if the patient's doing well on their current regimen.
Okay.
But the important thing to note here is that if a SABA-only reliever is used, then adherence to the maintenance therapy is paramount.
Right. So they've really got to be good about taking their regular medication if they're not using that combination inhaler.
Exactly, yeah.
Okay. The report also mentioned some other treatment options in those earlier steps, didn't it?
It does, yeah. So there are, other options listed for steps 1 to 4, like leukotriene receptor antagonists or LTRAs.
Right.
But generally, they have more limited indications, or there's less robust evidence to support their use compared to the medications in the 2 main tracks.
Okay. So those are kind of like second-line options if the first-line options aren't working or aren't appropriate.
Got it. So once someone's asthma is well controlled, does the treatment always stay the same, or can it be adjusted over time? So that's a great question, and the aim is always to use the minimum amount of medication necessary to maintain control.
Right.
And to minimize the risk of side effects. So once good control has been maintained for 2 to 3 months and there haven't been any recent exacerbations, treatment can be carefully stepped down
Okay.
to the lowest effective dose.
Yeah.
But this has to be done cautiously,
Right, I imagine.
especially in patients who've had exacerbations in the past or who have a low baseline FEV1 because they're at higher risk of relapse.
Right, right. So you don't want to just, suddenly yank them off their medication. If they've been doing well on it, you got to be careful.
Exactly. You have to be careful. You have to monitor them closely.
Okay, so we've talked a lot about medications, but what about other things that people can do, non-drug strategies to manage their asthma?
Yeah, non-pharmacological management is a really important part of asthma care, and one of the key areas is allergen avoidance.
Right.
So this involves identifying what the person is allergic to and then taking steps to reduce their exposure to those allergens.
Okay, so things like dust mites, pet dander, pollen, that kind of thing.
Exactly, yeah. So for indoor allergens like dust mites, pet dander, things like using special mattress covers and pillow covers,
Right.
washing bedding frequently in hot water, removing carpets, those kind of things can help reduce the allergen load.
Right.
The evidence for how much this actually improves symptoms is mixed. It varies from person to person.
Right. Right.
But for some people, it can definitely make a difference. And then for outdoor allergens like pollen, air pollution, it's harder to avoid exposure completely.
Right. Yeah, it's all around us.
It's everywhere, yeah. But staying indoors when pollen counts are high, using air purifiers, those things can be helpful for some people.
Okay, what about smoking? I mean, that seems like a pretty obvious one.
Yeah, smoking is a huge no-no for people with asthma.
Yeah.
It has so many detrimental effects.
Yeah.
It worsens asthma control, it increases the risk of exacerbations, it increases the risk of lung function decline, and of course, it has all the other health risks associated with smoking.
Right. Right.
So smoking cessation is absolutely crucial for people with asthma.
Yeah, absolutely.
Yeah.
What about exercise? I know some people with asthma, they worry about that. They think it might trigger their symptoms.
Yeah, so regular moderate physical activity is actually beneficial for most people with asthma, just like it is for the general population.
Okay, so it's not something to be afraid of.
It's not something to be afraid of, no. In fact, it can actually improve your heart health, your overall well-being,
Okay.
and there's some evidence that it may slightly improve asthma control and lung function as well.
Right.
Now, for people who do experience exercise-induced symptoms, using their ICS as prescribed, using their SABA as needed, and sometimes before exercise can be helpful.
Okay, so you can kind of pre-medicate if you know you're going to be working out.
Exactly.
Yeah. And for people who are using the ICS formoterol combination inhaler, that can also be used as needed before exercise.
Right.
Okay. Is there any connection between someone's mental well-being and their asthma?
Yeah, so there is increasing recognition of the link between psychological factors and asthma.
Right, right.
Things like emotional stress, anxiety, depression, all of these can impact asthma symptoms and asthma control.
Right.
And so addressing those mental health issues is an important part of asthma management.
Okay, so you really got to be looking at the whole person, not just their lungs.
Exactly, yeah.
The report also mentions social risk,
Mm-hmm.
and I'm not sure I fully grasp what that means in the context of asthma.
Yeah, so social risk factors are basically things like socioeconomic factors, housing instability, food insecurity,
Right.
all of those things that can impact someone's health. And it's interesting, there have been some studies, particularly in the US, that have shown that interventions to address social risk factors have been associated with reduced ED visits and hospitalizations for children with asthma.
Really?
Yeah. And it's thought that by addressing these underlying social factors, you can actually improve their asthma control.
Right, because if they're stressed about where their next meal's coming from or where they're going to sleep, that's going to impact their health overall.
Exactly, yeah. It all ties together.
Okay.
Hmm.
Are there any medications that people with asthma should be careful about taking?
There are, yeah. So some medications can trigger asthma symptoms in some people,
Okay.
and the most common ones are nonsteroidal anti-inflammatory drugs, or NSAIDs.
Okay, things like ibuprofen.
Yeah, ibuprofen, naproxen, aspirin,
Okay.
and beta blockers,
Right.
which are used to treat certain heart conditions,
No way.
and they're sometimes found in eye drops as well.
Right, right.
So it's important to be aware of those and to let your healthcare provider know that you have asthma if you're being prescribed any new medications.
Right, so they can factor that in. All right, let's talk about some other therapies and things to consider.
Mhm.
What about vaccinations?
Yeah, vaccinations are really important for people with asthma.
Okay.
The report recommends an annual influenza vaccination for people with moderate to severe asthma.
Okay.
And it also encourages everyone with asthma to follow local recommendations for vaccination against pneumococcal disease, pertussis, RSV, and COVID-19.
Right, so just staying up to date on all the recommended vaccines.
Exactly.
Okay. What about bronchial thermoplasty? I know that's something that's been mentioned in the context of severe asthma.
Yeah, so bronchial thermoplasty is a potential treatment option for adults with severe asthma that remains uncontrolled despite optimized medical management.
Okay.
And it basically involves using radio frequency energy to reduce the smooth muscle mass in the airways.
Okay, so it's actually a procedure.
It's a procedure, yeah. It's
Yeah.
usually done in 3 sessions, and it can be quite effective for some people.
Right.
However, it's important to note that it has been shown to have a significant placebo effect in studies.
Oh, interesting.
And it's also associated with an initial increase in exacerbations in the treatment period.
Really?
Yeah, so it's not without its risks. It's usually considered a step 5 treatment option, and it might be something to consider for patients who can't access or aren't suitable for biologic therapies.
Right. Right. Okay, got it. The report also touches on the environmental impact of inhalers, which
Right.
I think is becoming increasingly important as we think about climate change and our impact on the planet.
Absolutely. Yeah. So the propellants that are used in pressurized metered dose inhalers or PMDIs, they do contribute to greenhouse gas emissions.
Right.
And GINA supports efforts to encourage the use of dry powder inhalers where appropriate and also to develop more environmentally friendly propellants.
Okay.
However, it's really important to emphasize that these efforts should not disrupt access to essential inhaled medications, especially in low and middle income countries,
Right.
where access is already a huge problem. So it's a balancing act. We want to be mindful of the environment, but we also want to make sure that people have access to the medications they need.
Absolutely.
Okay.
Okay, so choosing the right inhaler, making sure people are using them effectively, that can all contribute to reducing the environmental impact.
Exactly.
Okay. One of the things that seems to be a really, really key part of good asthma management is patient education.
Yes.
The report talks about this thing called guided asthma self-management education.
Mm.
What does that actually involve?
So this is it's really about empowering patients to manage their own asthma.
Right.
And it has 3 key components: self-monitoring, a written asthma action plan, and regular review.
Okay, so let's break that down. Self-monitoring, what does that mean?
So self-monitoring involves patients monitoring their symptoms, sometimes their PEF at home using a peak flow meter,
Right.
and it helps them recognize early signs of worsening asthma. A written asthma action plan is basically a personalized plan that tells the patient what to do if their asthma starts to get worse.
Right, so it's like a step-by-step guide.
Exactly. It's a step-by-step guide. When to increase their medication, when to seek medical attention.
Okay.
And then regular review involves seeing their healthcare provider at regular intervals to review their asthma control, their treatment plan, their inhaler technique.
Okay.
And it's really important to highlight that studies have shown that guided asthma self-management education can dramatically reduce asthma morbidity.
Wow.
Things like hospital,